Welcome back. This is episode 7, and today we're diving into the next chapter. Let's get started. Chapter 7, Celebrating Motherhood. A great many damning things have been written lately about the mechanization of birth, and with good reason. The transformation of what should be a supremely human moment into a celebration of medical technology is demeaning and, in many cases, self-defeating. Recent studies and statistical analyses leave no doubt about that. But to my mind, one of the most devastating criticisms of the way we deliver children now is Dr. Michelle Harrison's stark account of a birth she witnessed one night as a house physician in a small suburban New Jersey hospital. That the delivery room happened to be in New Jersey is incidental. It could just as easily have been in any other American hospital, or French, German, English, Canadian, or Italian one, and that's what makes Dr. Harrison's account so compelling. In the delivery room, she wrote, "The patient was doing well when I arrived, mildly pushing, groaning, but not screaming. She had already successfully labored many hours alone, and I thought she would enjoy the rest. I gowned, gloved, then checked her. She was fully dilated and would deliver quickly. I draped her. Then the anesthetist arrived, a young man arrogant, and seated himself at her head. He placed a mask over her face and told her to breathe deeply. He reassured her it was almost over. She had only 2 or 3 contractions to go. I asked him what he was giving to her. He ignored my question. Minutes later, he decided to answer, but I couldn't hear what he mumbled. It didn't matter, though, because at that moment the obstetrician arrived. The anesthetist deepened her sleep to await the scrubbing and gowning of the OB. The OB stepped in, ignoring my presence. He and the anesthetist began speaking to one another. The patient was now choking on the tubes in her throat. Her labor had stopped. The table had been tilted forward so the OB could look down at the spreading lips. Then they spoke with contempt. The anesthetist was saying angrily that the woman was gagging. The OB said that she had stopped being any help to them. She wasn't pushing. Her uterus wasn't contracting. Forceps were unwrapped, applied, and with deepened anesthesia, the infant was lifted up and out of his mother's womb by the iron clamps about his head. He was blue and listless, but soon recovered with oxygen and some slapping. The obstetricians and the anesthetist went on talking while the patient was sewn up. They spoke of partners, of Puerto Rico, of vacations, weather, etc. The event of birth was lost to standard male locker room talk. Obviously, this is not a desirable way to bring a child into the world, or to treat an adult woman. Modern obstetrics can and must do better. The revolution in prenatal psychology has placed within our grasp a new birthright for our children, one that can make an immense difference to them, to us, their parents, and ultimately to society. We have the knowledge, we have the understanding. We only need to apply them. Since everything a woman thinks, feels, says, and hopes influences her unborn child, the kind of prenatal care she receives and the delivery alternatives she is offered should begin reflecting that fact. I am not suggesting that there is one best kind of birth. What works wonderfully for one woman may not work at all for another. But the alternatives available to an expectant mother should, without exception, be humane, effective, safe, meaningful, and appropriate. Birth is a celebration of life and hope, not a pathological disease state. Therefore, modern obstetricians must return to the basics, to baby catching, not surgery, to treating pregnant mothers as persons, not patients. It should allow a woman and her family their voice in all decisions concerning labor and delivery. To ignore an expectant mother's wishes and desires, as so often happens, is unconscionable. She has earned the emotional triumphs of pregnancy, and she has every right to enjoy that vital, integral part of her womanhood. An obstetrician has no business denying it to her by playing God as doctor. Harrison's story makes disturbingly clear, however, many obstetricians are unwilling to share the responsibility of childbirth with the mother. They were taught in medical school that birth is largely an engineering problem, and they seem determined, no matter their patient's wishes or what new research shows, to continue treating it that way. Fortunately, there are some exceptions, and while still not large, their numbers are growing. So too are the number of new family-centered approaches and programs which can help deepen and enrich the meaning of pregnancy and birth. However, No technique, no matter what its adherents may say, is suitable for everyone. An obstetrician, friend, or family member can provide advice and guidance in choosing, but in the final analysis, the decisions are the parents alone to make. Selecting among the various alternatives not only brings peace of mind, but it can provide the kind of reassurance that benefits both them and their child. This is not to say that there still won't be occasional twinges of anxiety. Even the best prenatal program available will not silence all doubts. These are a normal part of every pregnancy, and a woman would not be human if she did not have a few. But fears about stretch marks, changes in figure, or how she will stand up to the pain of labor can often be allayed through discussion with an obstetrician, midwife, friends, or a prenatal counselor. Knowing that a concern is universally shared brings a measure of relief in itself. So does familiarity. A labor room will not look nearly as intimidating or frightening if it has been visited beforehand, and neither will the doctors and nurses on the obstetrical floor if one has had the opportunity to meet them before the big day. A sense of perspective also helps, particularly when it comes to pregnancy's effect on the body. As a mother of 4, English prenatal counselor and anthropologist Sheila Kitzinger knows something about this subject firsthand. Even so, she is continually amazed by the results each time she asks her prenatal pupils to draw pictures of themselves pregnant. Even the happiest, most exuberant, expectant mothers see and draw themselves as dumpy, unattractive creatures. The fact that most pregnant women realize their situation is temporary distinguishes them from the high-risk mother who believes she is going to be rendered permanently unattractive, a subject I will expand on below. As Dr. Kitzinger rightly points out, this is a view few males share. The allure of the pregnant woman's body with its full, flowing lines gives many men a sense of real sexual pleasure, and women should be aware of that. Sometimes things you normally wouldn't think of, such as living space, can also create anxiety. One study showed that cramped quarters significantly soured feelings toward pregnancy. The more room a husband and wife had, the happier they felt about the pregnancy. Couples in houses felt better than couples in apartments, and so on. Obviously, one way of dealing with this is by making present living quarters more spacious. Another is by moving. The best time to make a move is before becoming pregnant, but if that is not possible, trying to find a home or larger apartment in the same general area is a wise course. As we've seen, moving during pregnancy poses some risk, but there is evidence that what upsets women is not the move itself, it's the move to an entirely new locality. Work also affects a woman's perception of pregnancy. I have found that women who are their family's sole means of financial support often make the poorest adjustment to pregnancy. In a study conducted by Dr. Helmut Lukesh, these women were frequently the most angry and resentful, which is understandable. In general, though, whether a woman is working at home, in an office, or not at all is, in a sense, beside the point. What truly matters is the sense of accomplishment and self-worth a woman gains from her work, because the way she feels about herself is going to affect the way she feels about her unborn child. In the final analysis, the normal, well-adjusted woman who feels good about her pregnancy will make the transition to motherhood smoothly as she makes every other critical transition in her life. The women and children in danger are those who enter pregnancy already in emotional turmoil, and unfortunately, many of them go unnoticed and unaided. Psychological screening is still not a routine part of prenatal care in most places, nor are many obstetricians, midwives, or prenatal counselors sensitive to psychosomatic effects of pregnancy. An expectant mother's nutrition, weight, heartbeat, and blood pressure are minutely monitored, but almost never her psyche. Unless a woman's distress is so obvious that those around her cannot ignore it, she is unlikely to be referred for psychological help. Inevitably, that means a large number of women who could benefit significantly from counseling never get it. The effects of this shortcoming are there to see, in the studies on stress and in the studies on pregnancy and birth complications. To be fair, though, many mothers who are emotionally at risk do seem perfectly normal. And in fact, many of them were normal until pregnancy ignited some dormant psychic conflict that had been established long before. A woman comes to pregnancy with a given history, a formed ego, and a practiced coping style. If and when her ego becomes threatened in some unforeseen way or her coping style collapses under the emotional pressures of pregnancy, then danger arises. And then, for her sake, even more for her child's, she should seek help. The emotionally high-risk woman tends to fall into one of three categories. The first and probably most common is the woman caught in an unsatisfying relationship. Pregnancy has a way of delineating the parameters of a marriage with intimidating clarity. All the little cracks and fissures that could be ignored before suddenly begin looking imposing. Doubts, long buried, spring up. What kind of mother will she make? Is he reliable? Do I want to be a father? Couples find themselves asking new questions of themselves and of each other, and if the answers they get are not satisfying, their relationship can deteriorate precipitously, with enormous consequences for their unborn child. The best time to ask such questions is before pregnancy, but if they arise during it, a couple should immediately seek some form of marriage counseling. One other significant relationship in a woman's life that may also affect her pregnancy and delivery is the one she had with her mother. A child learns her first lesson about mothering from her own mother. She is her daughter's initial and most influential role model. If she is a strong, supportive mother, it is likely her daughters will become one as well. If she is not, if she is uncomfortable or anxious in the role or feels inadequate, her child runs a greater risk of feeling the same way when she becomes pregnant, and that can lead to serious physical as well as emotional problems. One recent Swedish study found that what I will call unhappy daughters had a noticeably higher rate of birth and pregnancy complications than happy daughters. Of course, many women who related poorly to their mothers have normal pregnancies and grow into happy, confident mothers themselves. What such history does do, however, is raise the risk of incurring obstetrical complications. For that reason, such women should try to work out their conflict before becoming pregnant. Finally, there is a woman beset by fears and anxieties that are unusually intense and morbidly specific. Her concerns are not random, and they are easily laid to rest. In study after study, she is the one who exhibits the deepest degree of fear and dependence. She is at the mercy of her husband, her obstetricians, her mother, her friends. There seems to be no decision, however small, she can make alone. Her fears are often wildly irrational. First and foremost, she is concerned about what pregnancy is doing to her look. This is not a casual or passing concern, but near obsession. Each stretch mark becomes a harbinger of doom. She will never be slim or attractive again. Pregnancy has maimed her beauty forever. Her other obsession is the health of her child. Without any medical evidence, she is somehow sure he will be born deformed or irretrievably injured. These feelings can produce a wide range of potentially dangerous problems. One researcher, for instance, found that such women often have difficulty bonding with their infant after birth. A recent report from the University of North Carolina shows they also run a materially higher risk of incurring birth complications. Women in this study who had the longest labors, the most forceps-attended deliveries, and bore babies with the lowest APGAR scores also scored highest in testing on dependency, fears for self, and fears for baby. As I mentioned earlier, the keyword with regard to these anxieties is intensity. It is one thing to be consumed by such fears, and a therapist can help deal with that, and another to be legitimately concerned about one's self and one's child. A sensitive, understanding physician can help a woman deal with these worries. Next to your husband, he is the most critical figure in your pregnancy. Remember that delivery room scene Dr. O. Harrison described at the beginning of this chapter? It was not chance that brought the young mother's labor to a screaming halt. Strapped to the delivery table, in the middle of painful labor, she was at her most vulnerable when her obstetrician walked on. Had his attitude been more humane, the rest of the birth would have proceeded as smoothly as Dr. Harrison had expected earlier in the evening. Who delivers and how the woman feels about him or her makes that much difference. It is a difference that should be explored carefully beforehand. The first step in making a choice is deciding who is most suitable: a family physician, an obstetrician, or a midwife. For the physically high-risk mother, that decision has already been made. Her illness or her child's will dictate the use of an obstetrician. A woman who feels uncomfortable without a physician or equates a delivery without one with second-rate care is also better off with a doctor. The peace of mind his or her presence will provide could be important to her later during pregnancy and delivery. The best way to find a compatible doctor is through friends who have recently given birth. They will be able to provide the small but important details about personality and philosophy that are not included in the recommendations hospitals and county medical societies make. The next step is a personal interview, and it is best to interview several doctors before settling on a final choice. Be direct, and don't let yourself be intimidated by the white-coated figure on the other side of the desk. Remember, you are, or should be, the one who makes the final decisions. Ask about treatment philosophy. Is the physician going to be delivering the baby, or are you? What is he or she most comfortable doing? Will the doctor assist at the natural birth, or only at a medicated one? And what about his or her, and the hospital's, rules on fetal monitoring, ultrasound, anesthetics, episiotomies, shaving, and the use of enemas? Will your husband be permitted in the delivery room? Will your baby be allowed to remain with you after birth? And if your child is born premature or ill, will you be able to visit him in the hospital pediatric intensive care unit? The way these questions are answered is just as important as the answers themselves. You should be comfortable with your doctor. If he doesn't elicit a sense of trust in you, don't use him as your baby's assistant. This also applies to midwives, although they have a long and venerable history. Only since the late 1960s have they re-entered the medical mainstream in significant numbers. That very newness may make some women uneasy. But think of a midwife's important advantages. For one thing, her viewpoint toward birth is likely to be more sympathetic and humanistic. Unlike a physician, whose disease orientation trains him or her to see birth as a potentially serious state, the midwife's training teaches her to view it as a normal biological event. She is a specialist too, but in natural births, and the methods she employs reflect that fact. Episiotomies, fetal monitoring, prepping, all the normal paraphernalia of a medical birth are usually absent at midwife-assisted deliveries. Her orientation makes her receptive to innovations. Usually she is just as comfortable with, say, the Bradley method as she is with LeMay's, and is comfortable assisting in a birthing room. Another of her advantages is accessibility. She has more time to answer questions and is usually really interested in supporting her patients emotionally. A young woman I will call Marcia can attest to that. Her first child was delivered by an obstetrician, her second by a midwife. The midwife, said Marcia, made a difference. Toward the end of my labor, while I was pushing, she leaned over and said, "Help push your baby out." She used the word baby and she kept using it. The doctor had just said, "Push. Keep pushing." He made it sound mechanical. The word baby made it real. It reminded me that I wasn't there pushing as an abstract exercise. There was a real baby trying to come out. A midwife brings more than sensitivity to her task, and that is particularly true of a nurse midwife. Just to qualify for nurse midwife training, a woman first must be a registered nurse and have at least 1 year's experience in public health, as well as 1 year of inpatient hospital service. Usually the training itself takes anywhere from 18 months to 2 years. During that time, the midwife will normally participate in over 100 births. Added to the deliveries she attends once she has graduated, that often gives her as much or more experience in managing a normal pregnancy than a busy obstetrician. One of the other important choices a woman faces early in pregnancy is how she will deliver her child. When I was a resident at Harvard in the early 1960s, there were essentially only 2 delivery options available: medical vaginal or cesarean. All births took place in a hospital. Fortunately, that is no longer true. The women who came of age in the late 60s and early 70s entered their childbearing years with very definite ideas about the meaning of birth and who its chief beneficiaries should be. For the most part, they have been able to impose those ideas on obstetrics. Today, several types of natural childbirth preparation, as well as a wide range of delivery options, are readily available. As I have said before, I have no quarrel with the use of medical or cesarean deliveries for the physically high-risk mother or child. For normal deliveries, however, I strongly favor some form of natural childbirth. It puts control where it belongs, with the woman and her husband. The scale is human. There is none of the technical overkill that so often accompanies a medical birth. Most important, the child is allowed a gentle, graceful entrance into the world. And given everything we have learned recently about the physiological importance of birth, that fact alone makes a natural childbirth worthwhile. Just as important as the kind of delivery a woman chooses is the way she prepares herself mentally and physically. And the best place the right kind of preparation is a prenatal class. These classes not only provide instruction in pregnancy, labor, birth, and infant care, they also serve as a kind of extended family where new parents can meet and share their hopes, fears, and expectations. It's important to choose your classes carefully, as various prenatal programs offer their own distinct philosophies of childbearing. A woman who wants a structured delivery, for instance, would probably be very comfortable with the Lamaze method. Its emphasis on discipline and mastery is well suited for someone who likes to be in control. The ideal Lamaze woman is like a superbly trained athlete who has disciplined herself to perform under intense pressure. The analogy is not an idle one. She trains with the rigor and dedication of an athlete and approaches birth as if it were an Olympic event she is intent on winning. Winning, in her case, means remaining drug-free, awake, and playing an active role in the delivery. Lamaze classes stress controlling feelings such as fear or pain, which might get in the way of that goal. The woman learns how to ease contraction pain by relaxing her muscles at will, how to distract her attention through breathing exercises, and how to pace the delivery by psychologically and physically braking herself. To help achieve her goal, she must enlist the aid of another person, preferably her husband, who attends classes with her and acts as her emotional coach during delivery. In the late stages of labor, for example, he assumes command of the baby's passage down the birth canal, instructing his wife when to push and when to relax. Another popular form of birth preparation is the Bradley method. The emphasis is on everyone, mother, father, baby, and doctor, doing his or her part. One of the Bradley instruction films, Happy Birthday, captures this spirit nicely. It features a boisterous soundtrack, a beaming mother as star, and a supporting cast of T-shirt wearers. The doctor's shirt identifies him as the baby catcher, and the father's as the coach. Bradley preparatory classes stress the importance of feeling rather than just physical preparation. Husbands and wives are encouraged to discuss their marital and sexual problems openly in class, as well as their expectations about parenting and how they see themselves fitting into their new roles. Nutrition is heavily emphasized, and some pelvic and abdominal exercises are taught too. Unlike Lamaze, however, Bradley does not stress rigorous mental or physical conditioning. The technique is best described as relaxed. Women are urged to leave themselves open emotionally during childbirth, to express and embrace what they feel, rather than try to intellectualize and master it. All this makes Bradley a unique and, in many ways, an ideal way to have a child. Like Lamaze, however, it is not suited for everyone, including some first-time mothers. Bradley leaves a woman pretty much on her own during birth. Without knowing how she will react when she is actually in labor, a first-time mother may find the lack of structure a bit scary. A more logical candidate is a woman who wants to be able to set her own delivery goals, but who, having already had one child, is also confident enough of her reactions in delivery to turn the freedom Bradley offers to her own advantage. The last of the big three forms of natural childbirth, the Dick Reed technique, is also the oldest. Modified considerably since it was introduced in the late 1940s, it still remains at least ideologically the most straightforward. Thoroughly down to earth, it has none of the elan of Lamaze or the open, laid-back quality of Bradley. Adherents of the Dick Reed technique like to think of themselves as practical, placing a great deal of emphasis on the value of education and its ability to banish the fears and tension that produce many of the pains of childbirth. Dick Reed courses do teach coping skills, such as breathing exercises, but education is their priority. women learn what to expect and how to get support from others. Dick Reed also stresses what happens after birth. Couples often learn as much about the problems and challenges of parenting as they do about childbirth. It offers, in short, a pragmatic, sensible, and non-judgmental approach to birth. The Dick Reed technique does not require the degree of personal commitment other types of training do. I think a woman who would like to explore the idea of natural childbirth in a non-dogmatic environment will find its classes a good place to start. For all their differences, the one thing LeMays and Bradley do have in common with Dick Reed is an open-ended approach to delivery. A woman is free to choose the Le Boyer method, or what has come to be called a gentle conventional birth, a kind of hybrid that combines aspects of a natural and medical birth. Either one works with all three types of preparation. Of the two, however, Le Boyer is probably the more popular, though not among obstetricians, and is certainly the better known. For the past few years, it seems every magazine I have picked up has a story on the way it has changed birth. Briefly, a Le Boyer delivery is characterized by dim lighting, immediate skin-to-skin contact between mother and newborn, delayed cutting of the umbilical cord, and massage and bathing of the infant by his father. Le Boyer enthusiasts claim that this kind of gentling makes the child's passage into the world as positive and enriching as possible. While I agree that it does, I think the benefit comes not so much from Le Boyer's special effects, as from the facts that delivery is natural and compassionate. The mother is enthusiastic about it, and it allows the parents to begin bonding immediately with the newborn. Other forms of natural childbirth can also supply those three factors, as the results of a recent Canadian study show. After the publication of Dr. Le Boyer's book, Birth Without Violence, obstetrician Murray Enkin suddenly found himself swamped with requests from patients for Le Boyer-type deliveries. However, at that point, the method had not yet been tested in a scientific manner. So, with the help of several colleagues and his patients, who were chosen because they were expected to have uncomplicated deliveries, he decided to do his own study. He randomly selected one group of patients to deliver according to Le Boyer. Another group delivered by a gentle conventional method, which might best be described as Le Boyer without the trappings. The baby is born naturally and drug-free, but the lights are not dimmed. His umbilical cord is clamped a bit earlier, and he is not bathed or massaged. He also does not have immediate skin contact with his mother. Reviewing the results, Dr. Enkin found that, with one notable exception, there were no significant differences in outcome between the two groups. Women in both groups had about the same rate of complications, which incidentally were low, and were nearly as likely to ask for an anesthetic to ease their labor pain. The one exception was the much shorter first-stage labor times of the Le Boyer mothers, a fact Dr. Enkin thinks was due not to the method of delivery, but to the women's enthusiasm about it. No important differences emerged among their children either. Initially, the Le Boyer babies were slightly more active and energetic, but by the third day, the other group caught up. More significant was Dr. Enkin's failure to find any evidence to support claims that the Le Boyer method of delivery is more soothing for an infant. Despite the bathing and massaging, the Le Boyer babies cried as readily as the other infants. His conclusion that both delivery methods were equally safe and effective seems thoroughly justified, as does his assertion that what really matters is that the birth to each couple's and each baby's individual needs. That involves more than just selecting an appropriate form of delivery. Where a woman decides to bear her child can be just as important as the method of delivery she chooses. The setting should make her feel comfortable and relaxed, be appropriate to the act of birth, and also be safe. More and more mothers believe that while a hospital delivery room meets the last of these requirements, it does not meet the first two. These women have been turning to alternative birthing places. One of the most popular and controversial of these is the home. The home birth advocates say that birth rightly belongs in the home, and I agree with them that a home birth has real advantages. Living with birth and death on a daily basis gave our ancestors a much surer and saner grasp of life's rhythms and revelations than we have. The problem is, Are home births safe? In the next few years, as more data begin to accumulate, we should have a much clearer idea. But at the moment, there are so few hard statistics on its safety that, as much as I would like to, I hesitate to recommend it. The studies we do have are unsatisfactory. A recent one conducted in Oregon illustrates why. On the surface, the report seems to be a clear-cut condemnation of home birth. The investigators found that babies born at home had nearly double the death rate of hospital-delivered infants. On closer inspection, though, the study turns out to be full of flaws. For one thing, a large number of the home birth movement's most fervent advocates oppose unattended deliveries. For another, the study only looked at reported home births, and all indications are that significant numbers of such births go unreported. Still, the very one-sidedness of the figures should not be ignored. Two alternatives that attempt to combine the medical protection of a hospital with the relaxed atmosphere of a home are in-hospital birthing rooms and maternity or birthing centers. In-hospital birthing rooms are usually private or semi-private rooms that have been curtained and painted to add a touch of warmth. Inevitably, they never look as warm as the hospital brochures make them sound. But for all that, they have some distinct advantages as birth settings. One is that the couple, not the hospital, gets to set the rules. Within reason, they can have whomever they want in the room during the delivery, and there is almost no limit on how long the baby can stay after birth. Many women find that fact alone makes an enormous difference. What bothered me most about my first baby's birth, one woman told me, was having him whisked away immediately. I was still wide awake, and I wanted to hold him for a while. But they wheeled me right back to my room, which was unlit. My roommate was trying to sleep and didn't want the light on. And after my husband went out to make some phone calls, there was no one to talk to. So there I was, 30 minutes after having a baby, sitting in a dark room alone, with nothing to console me but a bag of lollipops I had brought along. I felt terrible. At her midwife's recommendation, that woman elected to have her next child in a birthing room. Everything was so much more peaceful and joyful the second time, she recalled. There were no machines around. My husband was able to stay with me, and I kept the baby for several hours after delivery. She even found her labor was different. It went so much easier. Afterward, I couldn't believe how great I felt. After the first delivery, I was a physical and emotional wreck for a month. Independent maternity centers are not yet as widely available as birthing rooms, but their numbers have grown rapidly over the past few years, and I think they will continue to do so. Of all the alternatives, to me these centers seem to come closest to providing an ideal birth setting, a warm, home-like atmosphere combined with good medical backup. For example, at one of the best-known birthing centers, the Childbearing Center in New York City, a woman gets a living room, a kitchen, an outside garden, and 2 bedrooms, one for herself and one for her support person. At maternity centers, rules and interference tend to be minimal. Immediate family members are permitted to attend the birth, and the infant is normally allowed to remain with his mother for an hour or so after birth. Medically, the centers are not designed to match big hospitals. They only admit low-risk mothers to minimize the chance of emergencies, and are staffed largely by nurse midwives who provide most of the care, including doing the deliveries. Each center usually has an obstetrician on call to handle emergencies and a pediatrician who examines the baby after birth. Their aim, like that of the other settings and techniques discussed in this chapter, is to rescue birth from technology and restore it to its rightful place in the family. I believe this benefits the mother and her child, and, in the long run, all of us. Chapter 7 is now complete. That's it for today's episode. Stay tuned for the next one. Until then, take care and see you soon. Thank you.